Good night to all, and welcome to the second virtual session of the COVID-19 Aftermath Symposium. We have some wonderful speakers who will be presenting to us this evening. Four dynamic speakers will be speaking to us on various topics that have impacted all of us during this COVID-19 aftermath. Our first speaker is a veteran psychiatrist who is well known and a household name, I would say, in the Bahamas, and certainly world renowned. He is a consultant psychiatrist, and he has specialized in mental health for many, many years. And to assure that he is well equipped to speak to us on the topic, the mental toll of the COVID-19 epidemic. Following his presentations, we will allow a few questions once time permits. Dr. Timothy Barrett will be our first speaker. Let's welcome him. Dr. Barrett.
Good evening, everyone. And I certainly am very honored to be able to speak with you this evening on the subject of the mental health effects of COVID-19. We have been doing this now for almost a year, and half the end is in sight. But hopefully, not only the vaccine, but the attitude towards vaccine will help us to move a little quicker to the elements that to have in place to get past this. So this is my agenda. We only have a few minutes, so we can't be extremely comprehensive, but I'm going to go through a brief chronological history. I'm going to discuss that there is more than one pandemic. I'm going to look at the unique experience for Bahamians, and then talk generally about reactions triggered by pandemics, infectious diseases pandemics. Briefly touch on three categories of population. Speak to the issue of the effect on healthcare workers and frontline workers, effect on children, tips on children and youth, and then the important area of grief and mourning during this COVID crisis. And then just some take-home tips on taking care of your health, body, soul, and spirit. In early January 2020, China notifies WHO of a pneumonia of unknown etiology. By the 13th of January, the first case of the novel coronavirus outside China was reported. On the 21st of January, the CDC confirmed the first US case in the state of Washington. And on 23rd of January, China enforces a complete lockdown of Wuhan City, the first in the history of the world. January 30th, WHO declares a global public health emergency. On February 11, the novel virus is given the name SARS-CoV-2. March 11, WHO declares COVID-19 outbreak a pandemic. And interestingly enough, March 16, Moderna begins phase 1 and 2 trials of its mRNA vaccine. And in April, Pfizer, BioNTech, and AstraZeneca begin their trial. And in May 2020, the US government announced Operation Warp Speed. And probably the most important thing that happened in relation to the vaccinations is that in September, a collaboration on vaccines is launched, a global collaboration called COVAX. Now, I said there's more than one pandemic. What do I mean by that? The announcement of the global pandemic and the identification of SARS-CoV-2 as the infecting agent was the first pandemic. However, the next pandemic was the pandemic of fear and uncertainty, especially in relation to the fear of dying from the disease, COVID-19. And then, of course, the third pandemic was the global disruption of national economies as cities went into lockdown mode, businesses and borders were closed and jobs were lost. Now, why is the Bahamian experience unique? Well, this thing is happening within 6 months of our Dorian experience that devastated two of our northern island territories, displaced many people, destroyed many homes, killed many citizens, and disrupted the economies of the areas that were so affected. Not only that, but when we first went into lockdown mode, that was 3 months before the start of the next hurricane season, which begins June 1. But the most important thing is economic dependence on visitors and tourists, and all places who were bringing in tourists had to let their people go. Some people lost jobs and are not going to get them back. But we are a religious country, and a lot of people disregarded what was being told to them because they didn't want to claim it. I'm not claiming that. In addition, the stigma and therefore lack of prioritization of our mental health meant that we didn't have mental health along with all the other foci on the important health issues and possible health consequences. Mental health wasn't equally as important. And as a country, we have a general tendency in the community to not obey rules. That's unfortunate. As we can see in a place like Taiwan, where there's a deference to authority and people are prepared to obey rules, they had a very, very good result from their early intervention. Now, reactions that are triggered by these kinds of situations that affect our mental health involve fear and worry about one's own health and the health of our loved ones who may be exposed. There's the fear of dying from the virus infection, COVID-19. There are changes in eating and sleeping patterns. There's a common referral now to COVID belly. I don't know if any of you have acquired COVID belly, but I've seen many people who that's their excuse for the belly, that is. The fear and the worry and the uncertainty cause concentration difficulties, and there are many distractions because all day we are bombarded with information and news coming from everywhere and anywhere in relation to the coronavirus, COVID-19, and what's happening in various parts of the world. Then, with quarantining and lockdowns or sheltering in place, we have the feelings of being overwhelmed, isolated, and lonely if you're not in a house with a lot of people. But even if you're in a house with many people, you're separate from your friends. Children and adolescents are separated from their classmates, and they start to realize for the first time how important it was to be with classmates. We start to realize how important it is to socially interact with our friends. If you had chronic health problems, because the focus was now mainly on SARS-CoV-2, COVID-19, you may not have had the right amount of attention paid to your chronic health problems, with the result that it worsens. And then there's the increase in anxiety, depression, other psychiatric disorders. A lot of people succumbed to increased use of alcohol, tobacco, or other drugs. Now, for a while, our liquor distributors and our bars were closed. And of course, we got that song, Minutes I Thirsty. But people found a way to get their alcohol. They found a way to get their drugs. And there was generally an increase in use and abuse of alcohol, tobacco, and other drugs. As time went on, impatience led to people not following the disciplines that were recommended by the infectious diseases specialists and the epidemiologists. In particular, I suffered from an inability to travel, and we love to travel, but we couldn't travel. And then there is a phenomenon that has been called psychic numbing. The longer the pandemic lasts, the more people have difficulty connecting the information that they receive to an emotional connection. So there's a detachment. And so the problem seems lessened, and that seems to be a psychological adjustment. Then you have the mental health effects during COVID-19 and after COVID-19 infection. 1 in 5 people who were diagnosed with COVID-19 are now known to have a co-infection psychiatric problem of some sort. I just want to briefly discuss 3 categories of population. The first one is persons at risk, most at risk, who have a history of psychiatric psychological disorder. When the stress of coronavirus and COVID-19 was at its peak, and with chronicity and prolongation of the periods of curfew, sheltering in place, isolation and quarantine, those persons were more likely to have a relapse of their psychiatric disorder, psychological condition. And then there's the second category of the population, persons with no history of psychiatric or psychological disorder, who have what is known as low resilience. In that category of persons, the risk for developing anxiety and depression are doubled. The third category is persons with no history of psychiatric or psychological disorders, but with high resilience and significant. In that category of persons, the risk for anxiety is reduced by about 65%, and the risk of depression is reduced by about 70%. So we see the key importance of resilience and resilience, and I'll briefly touch on this towards the end. In particular, we need to make sure that we understand that the effect on healthcare and other frontline workers was the area of most importance that we really needed to focus on in relation to their mental health. There was the frequent exposure to the possibility of infection on a daily basis. There was the worry about taking the infection back home, and just I read something before I came on, in that even though you may have neighbors who would allow their children to play with other neighbors' children, if you were a frontline worker, they didn't want their children to play with your children because of your increased risk, because you were a frontline worker. And we had to adapt as healthcare workers to frequently changing protocols in the workplace, PPEs, and making sure that we did everything that we could possibly do to take care of the patients in an appropriate way, while at the same time protecting us. We found ourselves in healthcare working longer hours. We were exposed to increased mortality. A lot of times people knew. There was lack of the availability of usual leisure activities, with resulting increased levels of distress and burnout, with no organized peer support or psychological services provided. I know a nurse that worked in the intensive care. I come across a doctor's hospital on a regular basis. And she said, she's been a nurse for years. And she said to me, for the first time in 30 years during this period, she did not feel like coming to work for the first time in 30 years. And I think that is so significant. But what's the effect on children? Signs of regression. Regression to a previous stage of development. So bedwetting or toilet accidents, excessive crying or irritation, so emotional changes, acting out, behavioral manifestations, unhealthy eating or sleeping habits. A lot of children stayed up very, very late at night, playing games or being otherwise involved with their technology. Difficulty with attention and concentration. You know, right now, most learning is online. We have children going back to school, fortunately now, and that's going to happen more and more worldwide. But with online learning, they had difficulty with attention and concentration. They had avoidance of activities enjoyed in the past, and they may have presented with somatic symptoms, headaches or other body pain. And the adolescents, like the adults, had increased use of alcohol, tobacco, and other drugs. Now, in relation to the children and youth, parents need to be sure to talk with their children to find out how they're thinking and what they're feeling, because we can't just leave them and feel that it's not affecting them in a significant way. We as adults, we need to stay calm and reassure our children that they are safe and show them that know how to cope with the stress of all the changes that are going on in our world and in our nation. We should make sure and limit their exposure to media coverage. Ensure they stay active in some sort of way, especially to go out in the yard and engage in outdoor activities. Develop a regular daily routine so that there is predictability. And when not in school and not having to attend school, engage in activities that exercise the brain, even when not in school. Make sure that they stay connected with family and friends through social media. I think we understand now, though, that even though social media is the way of connecting of choice now, we see how inadequate it is and how much we need that face-to-face, that touch, that hug, that conversation with someone without the mask on. And we long for that. Grief and mourning. Loss is difficult under normal circumstances, loss of a loved one, but even more difficult during a pandemic with all its restrictions and the inability to carry out the normal social rituals. The delays and physical distancing severely interfere with the mourning process. And don't know what effects this is going to have on persons who have to go through this during this period. We have to wait and see. That's a very fertile area for study. And then finally, taking care of your health. Self-care is very important, especially for us who are healthcare workers and who are considered frontline workers. All of us are under stress, but some of us more than others, depending on your ability to cope and your resilience. So you need to assess your capacity and try and improve that by reading about how to improve coping or getting in touch with somebody discussing. Make sure you get adequate sleep, and that's so important. You need to rest, relax, and refresh, and sleep is part of that. Exercise daily, a little something, 10, 15 minutes. That really takes care of and allows you to go through the distress with less tension, especially muscular tension. Do not comfort eat and choose a well-balanced diet. In fact, eat smaller amounts frequently in the day. Less food on your plate. Make sure you don't come to this with problems that you now have to work on afterwards. Avoid tobacco, alcohol, and drugs as coping mechanisms because they're not good coping mechanisms. Limit your screen time in relation to social media. I think we can all probably limit our screen time a little bit more effectively now that one Mr. Trump is not still getting all our attention. Review your priority list and use it as your guide. You should have what is important to you. You should have a list of priorities. You should have worked that out. And then that's what you use to guide what you choose to do first and foremost so you get the most important things done and you are effective. And last but not least, use this opportunity to meditate and develop your spirituality, your relationship with the God that you serve, because it is that that gives us the hope that prevents us from increasing worry, increasing distress, increasing uncertainty when we have a spiritual being that we can call on who's greater than God. And so that's the end of my presentation. I'm willing to take any questions now in relation to what was presented. And even if you didn't see anything, something presented here and you want to ask questions, that's quite fine. Thank you very much.
Thank you, Dr. Barrett, for your presentation. Excellent presentation as always, Dr. Barrett. Thank you again for your words to us for the mental health during this aftermath of COVID-19. And we will now get ready for our second presenter, who will be speaking to us today on treating the infected COVID-19 patient, the search for the Holy Grail of therapy. Coming to speak to us this afternoon is another well-respected physician, a young man who is a consultant infectious disease specialist at the Princess Margaret Hospital, as well as Doctors Hospital, our very own Dr. Charleon Bonamy. Let's welcome him as he speaks to us during this virtual symposium this evening.
Good evening, everyone. Thank you to the organizers for the invite. My topic, treating the infected COVID-19 patient, the search for the Holy Grail of therapy. Now, the early part of this pandemic was somewhat daunting. SARS-CoV-2 being a new pathogen, we obviously were faced with significant knowledge gaps ranging from transmission to disease complications and from management to prevention. We were dealing with a disease with a significantly high mortality rate in patients admitted to hospital with no known treatment and limited understanding of how to manage the disease initially. And so we've had to balance the need to fill these gaps as quickly as possible with limited quality of evidence available. Most of the early reports unavoidably were based on observational and retrospective studies. And unfortunately, with that, you have inherent limitations, including small sample sizes, confounding, selection bias, inadequate controls, lack of blinding, and so on. And so rapidly, people identified many potential therapies that they thought might work, many repurposed drugs, things that worked against related viruses or things that looked active in vitro. And we needed to figure out which treatments were the most effective, and we had to do it as quickly as possible. So this evening, we're going to explore the spectrum of COVID disease and recognize its importance in understanding our therapeutic options. We'll have a look at the trial strategies that have been deployed to help us navigate these therapeutic options. And we will review the evidence from a few of the studies that have helped frame our therapeutic management. When we look briefly at the spectrum of COVID disease, we see it ranges from people who are or pre-symptomatic to people having mild disease, which can have a variety of symptoms, including fever, cough, sore throat, loss of taste or smell, without shortness of breath or any abnormal imaging. And for the most part, the majority of people will fall into this category of mild illness. Then progression to moderate disease where hypoxemia occurs and there's evidence of lower respiratory tract disease, and then more severe and critical illness. And so when we think about therapeutics and what we use to treat, we have to keep in mind that agents can be effective at one end of the spectrum and potentially not at the other. Another way to look at it from a pathophysiological standpoint is that as people progress from asymptomatic infection to symptomatic disease, the underlying pathophysiology changes. And so viral response may be important in early disease, and then the host response takes over midway. And so some of the severe manifestations of disease may be more related to the host response than the underlying virus itself. So when we think about our therapies, we have to keep in mind, what stage of the disease are we treating? Are we targeting the viral stage, which is usually in the early phase, or are we targeting the host response stage? And as we attempt to, navigate this landscape, we can identify many opportunities where you can evaluate the effectiveness of certain therapies from the pre and post-exposure periods and persons in the outpatient setting, where you think about antibodies and antivirals to perhaps block infection, to your mild hospitalized disease patients where immunomodulators might be added. And then there's a transition from this mild to severe hospitalized patients where you might potentially add interleukin-6 inhibitors or other inflammatory and antithrombotic agents that may prove to be beneficial. Then the other phase where therapeutics is warranted and strategies for treatment need to be evaluated is in this recovery phase or this post-hospital period where people leave the hospital and they still have complications thereafter. Early in the pandemic, the focus was mainly on therapeutics in our hospitalized patients, but we've certainly now arrived at a point where we're seeing a lot more attention being paid to therapeutics throughout the spectrum of illness. When we look at the pathogenesis and life cycle of SARS-CoV-2 infection, we identified early many possible viral targets for using these repurposed drugs that potentially, might have been effective. So for example, where the virus attaches to the ACE2 receptor, blocking the viral entry. As it begins to replicate, there was in vitro evidence that, hydroxychloroquine and azithromycin might acidify these vesicles and inhibit the replication of the virus. Then you have targets like remdesivir, which are direct acting antiviral agents that inhibit RNA polymerase. So early on, we had this surge of agents initially being identified as potential therapies for investigations. And because it was so many early on and so many to choose from, it was a bit confusing and complicated as to how we were going to sort through all of these potential treatments, figure out what was and what wasn't going to work, and perhaps more importantly, which ones might have been harmful. And so at the time, we had tons of observational studies being conducted, which was obviously expected, but certainly not the standard to which we are accustomed. And so we know and have known that randomized controlled trials are the tried and proven way of evaluating the efficacy of new interventions, particularly in the context of a new disease. And they have the ability to assign and administer treatment or intervention in a precise or controlled way. It allows us to compare groups that are balanced, not only for characteristics that we can measure, but certainly for those that we can't measure that have the ability to really impact disease. And unfortunately, during a new disease like COVID, we just don't know which things we're able to control for or need to control for. And so these trials, they help to limit bias by blinding. It gives us an unbiased assessment of outcomes, including safety outcomes. Unfortunately, there are a number of challenges to conducting these trials, especially in the midst of a pandemic. So logistics with regards to testing and turnaround time, limitations in supplies like PPE, procuring nasal swabs, personnel to conduct trials, they're all limited. You have lack of infrastructure to carry out trials, certainly restrictions and quarantine, particularly in places that are looking to conduct trials in ambulatory patients. If infected individuals can't move around, it's pretty difficult to conduct research on them. And yes, observational studies, they do add value, but in the setting of a new disease, particularly when we're thinking about therapy, where the natural history is undefined, we need to rely on our randomized controlled trials. And so one of the game-changing strategies that allowed us to kind of figure all of this out in a logistically effective manner was the utilization of the adaptive platform trial strategy. And these trials are an innovative way to evaluate alternative treatment strategies. And they refer to a protocol where you can ask multiple questions and about the effectiveness or interventions for a disease. And information during the trial, they can be altered and subsequent operations changed in an adaptive way. And what the trial does is it allows for the placebo arm, for example, to be shared across multiple different treatments, hopefully being able to yield results sooner. And these trials, they adapt to new information that is learned. So for example, if an agent is found to be effective, it can become the standard of care. And arms performing poorly, they can be dropped and new ones added. And so with this strategy, being able to integrate evaluations within a single trial is something that's really important in the setting of a pandemic when you keep in mind access and resources and logistics of conducting trials in the midst of a pandemic. So in April, the National Institute of Health, they launched a public-private partnership called the Accelerating COVID-19 Therapeutic Interventions and Vaccines, or ACTIV, to try to develop a coordinated research response to speed COVID-19 treatment and vaccine options. And its goals were to establish a collaborative framework for prioritizing therapeutic candidates and accelerating vaccine evaluation, as well as to accelerate clinical trials of promising agents and leveraging existing clinical networks while maintaining rigorous safety and design standards. And what ACTIV has done was to work to gather data to identify clinical agents, categorize them into these 4 groups. So your antivirals, immune modulators, symptomatic and supportive and neutralizing antibodies, and try to prioritize those agents into inclusion into studies. When we reflect on the lessons from hydroxychloroquine, there were early reports or early studies that suggested that it might be beneficial, and certainly in vitro data that showed that it had activity. Then we had a series of observational studies that suggested there was limited efficacy and potential toxicity, particularly in the sickest patients. And this, obviously became politicized, and so hype, misinformation, political pressures may have led to false hope and hasty decisions very quickly. And it had a detrimental effect with regards to our ability to conduct high quality research, particularly using hydroxychloroquine. Nevertheless, randomized controlled trials were eventually done, but due to the hype and politics and logistical challenges, outpatient trials with hydroxychloroquine were very difficult to conduct, but nonetheless did show hydroxychloroquine not having a benefit in that setting. Then in the hospitalized patients, we had the recovery trial, which showed no evidence in the improvement of 28-day mortality with hydroxychloroquine use. And so, with this lesson, I can't really stress enough the importance of scientific rigor in times like these. I know it's exciting to see and read up about all the new agents that are being utilized, but we must pay close attention to the quality of research and the subsequent peer review. This map here shows the infodemic with regards to the ongoing clinical trials being performed. We have over 200 drugs being studied and more than 2,500 clinical trials underway. And the fact that, over 200 drugs are being looked at, and knowing what we know about pathogenesis, the spectrum of illness, and our own limited success with effectively treating other viruses may tell us that we'll probably find the real holy grail before finding an agent that will effectively treat everyone with COVID. And so prevention is certainly better than cure here. Nonetheless, there still exists a need for high quality clinical trials to inform treatment decisions. A good point of reference that I use is this website, clinicaltrials.gov, or the PAHO website. On their website, they look at about 40 to 50 of the therapeutic trials, and they give updates on their process and the progress. So you can certainly stay abreast of what's being done in some of the agents you may have the most interest in. So what I'm going to do is discuss those trials which have impacted our clinical management thus far. So the recovery trial, this was a platform trial designed to rapidly test therapeutics in hospitalized patients, and it was started in the United Kingdom with the initial treatments of hydroxychloroquine, dexamethasone, convalescent plasma, azithromycin, lopinavir, ritonavir, what we know as Kaletra, the HIV drug, and tocilizumab, the interleukin-6 inhibitor. And it was a simple trial, started on April 3rd, where hospitals in the UK, they enrolled their patients into the trial. Then as early as June 5th, they found no benefit of hydroxychloroquine. By June 16th, dexamethasone was found in their trial to reduce mortality by a third in patients who were on ventilators. And on June 29th, they found no benefit of lopinavir, ritonavir. And so you can see quickly how this trial was able to report out major results across multiple agents by using this platform design. And the trial since then have added other agents, including the monoclonal antibody combination, the casirivimab and imdevimab, which is the Regeneron antibody cocktail that former President Donald Trump received, as well as they added both arms of aspirin and colchicine. When we look at the dexamethasone arm, they randomized 2,000 participants to dexamethasone and 4,300 to the standard of care. And they gave those dexamethasone patients 6 milligrams up to 10 days. And their primary outcome was all-cause mortality within 28 days of randomization. Overall, there was statistically significant benefit with use of dexamethasone, especially in patients who needed ventilation, but also in patients who received oxygen. They didn't find any benefit, though, in individuals who did not receive oxygen, and the suggestion of potential harm in this group. So certainly in outpatients and inpatients who don't require oxygen, this is perhaps not the group you would want to give dexamethasone to. This is a nice meta-analysis that looked at the use of systemic steroids in critically ill patients, which showed that there was a benefit also from these other corticosteroids. So certainly dexamethasone, hydrocortisone, and methylprednisone. And so all of your major guidelines recommend the use of dexamethasone in hospitalized patients who require oxygen support. Remdesivir is another major advance in clinical trials that was conducted early in the COVID-19 pandemic. It's a nucleotide analog that inhibits RNA polymerase, and it was FDA approved in October. And there were two big randomized controlled trials looking at its efficacy in hospitalized patients. The first was the Adaptive COVID Treatment Trial, or ACT-1, and the second was the World Health Organization Solidarity Trial. In ACT-1, this was a multinational, randomized, double-blinded, placebo-controlled trial whose primary endpoint was time to recovery. And in this trial, remdesivir had a median recovery time of 10 days compared to 15 in the placebo group, which was significant. And it too demonstrated that the benefit was seen mostly in patients who were receiving low-dose oxygen, certainly not in those who needed high flow or non-invasive mechanical ventilation, and definitely not in patients who were ventilated and required ECMO. The mortality at day 29 was 11.4 in the remdesivir arm and 15.2 in the placebo arm, which wasn't statistically significant. The premise, though, is that although you don't have a mortality benefit, the ability to influence time to recovery sooner rather than later potentially allows for you to discharge patients sooner, which may assist with bed capacity and certainly is important during a surge. I haven't read any about any institutions or places that have looked at this premise, though. The other trial was the World Health Organization Solidarity Trial This was international open label randomized trial that looked at patients with COVID-19. Open label simply means that the physicians knew which patients were receiving which medications, and their goal, they studied 4 repurposed antiviral drugs on mortality. So your remdesivir, hydroxychloroquine, lopinavir, ritonavir, and interferon. And the hydroxychloroquine, the lopinavir, ritonavir, and interferon were dropped from the trial due to futility in their patients. 2, there was no effect of any of the medications on mortality, in initiation of ventilation, nor duration of hospital stay. So remdesivir in their trial didn't work either. So the World Health Organization does not make a recommendation on the use of remdesivir for hospitalized patients. The NIH and IDSA do recommend remdesivir use in those who require oxygen, but WHO does not. When pressed on their thoughts with regards to Solidarity's findings, the IDSA panel felt that because Solidarity trial was open labeled and therefore lacked blinding, it was not the best trial to evaluate time to recovery as compared to your Act 1 trial, which was double blinded. And so they continued with their recommendation for remdesivir use. The only recommendation with regards to medication that WHO recommends are corticosteroids in patients with severe or critical COVID pneumonia. And so with the addition now of remdesivir as standard of care in your adaptive clinical trials, they now have the ability to compare remdesivir as the standard of care to other therapeutic options, including combination therapy that include remdesivir. And so in their Act 2, they compared combination therapy remdesivir along with the Janus kinase inhibitor baricitinib. And this medication is involved in the treatment historically of rheumatoid arthritis, and its proposed benefit is twofold as an anti-inflammatory as well as potential antiviral activity. And they compared this combination to remdesivir plus placebo. The results were pretty marginal. An improved median time of recovery by 1 day. Participants were more likely to experience clinical recovery by day 28, and they were less likely to require initiation of mechanical ventilation or ECMO through day 29. There were some concerns about the use of this medication due to its historic risk for thromboembolic phenomena, immunosuppression, and development of superimposed infections, and the fact that the dose used in the Act 2 trial was twice that which is commonly used to treat rheumatoid arthritis. Nevertheless, despite the marginal benefits and potential side effects, the data has led to the recommendation of the combination of remdesivir and baricitinib rather than remdesivir alone for hospitalized patients with severe COVID-19 who cannot receive corticosteroids due to contraindications. Antibody therapy is also a hot topic of discussion. These are laboratory-produced virus-neutralizing monoclonal antibodies that are directed against the spike protein on the surface of the virus. And you know the spike protein, it attaches to the ACE2 receptor on the host cell, leading to viral entry into the host cell and subsequent viral replication. And so the goal here is to bind to this protein, prevent its attachment, and therefore prevent subsequent viral replication. And the 2 antibody therapies that have gained ground are the bamlanivimab and the combination product of casirivimab and imdevimab, so the Regeneron. And these have been studied in different patient populations. Essentially, you're hospitalized and outpatients. And in the hospitalized, they found no benefit. And perhaps we should have predicted that because primarily most hospitalized patients, if you think about your spectrum of disease, most of them have already mounted an immune response. And these medications, though, have received emergency use authorization in ambulatory patients, so your outpatients, but their routine use have not yet been recommended. And this EUA pretty much stemmed from their phase 2 trials, which showed very similar results. Both medications demonstrated a shorter time to symptom improvement. And then most importantly, they both resulted in a lower proportion of COVID-19 related hospitalizations. And so decreasing hospitalizations in a time when capacity has been reached is a critical outcome. The EUA also recommends the use of these monoclonal antibodies in specific high-risk ambulatory patients. So those who have an elevated BMI, those with chronic kidney disease, diabetes, the immunosuppressed, those over 65, or if you're greater than 55 with certain cardiovascular disease. And so as we think about outpatients who are at high risk for hospitalization and deterioration, the idea of utilizing the strategy to intervene early may have an impact on their morbidity and mortality, and potentially minimize emergency room and visits and potential decreased hospitalization rates. Just briefly on tocilizumab, the interleukin-6 inhibitor, the thought was that due to the hyperinflammatory syndrome and elevations in interleukin-6 levels in COVID patients, perhaps blocking interleukin-6 may mitigate the hyperinflammation associated with COVID-19. There have been about 5 randomized controlled trials looking at the effects of tocilizumab in hospitalized patients. They've all, none of them have showed a benefit in 28-day mortality. And there was one trial, however, that did demonstrate a lower risk of clinical deterioration, the need for mechanical ventilation or ICU admission compared to placebo. Again, the idea of potentially, utilizing a medication that, despite the limited mortality benefit, may have other uses like decreasing the need for mechanical ventilation in a time where there's ongoing resource limitations is important. However, the evidence was of low certainty due to risk of bias and imprecision in that study. And so tocilizumab is currently not recommended for routine use in hospitalized patients. And so this was just a snapshot from the PAHO's ongoing, living update on potential COVID-19 therapeutics. As you can see, the trials under investigation here on the left, they analyze these trials with the grade system, and the black and gray that you see means that there's actually no evidence on uncertain effects. So for example, hydroxychloroquine here in yellow and red showed no beneficial effect and even harmful effects with hydroxychloroquine. With lopinavir, ritonavir, no beneficial effect. Remdesivir, in this light green, has a beneficial effect, but low certainty. And the only one with a strong green beneficial effect were corticosteroids. And so, we've made some advances with finding therapeutics that have improved patient outcomes since the pandemic has begun. We still have a long way to go, though, to find the holy grail of therapy. The use of innovative ways to conduct rigorous scientific trials have certainly helped to guide our path. We must continue to stay on this course and not be tempted or distracted by medications and low quality data. Even if we find that therapy, it is anticipated that there will be challenges to access, procurement, and distribution. A medication that's expensive and perhaps may not be able to be distributed equitably. And so adhering to public health recommendations and the prospect of vaccinations, although seem less exciting and opulent, may be our best chance to combating this disease. And I thank you, and I'll just open the floor if there are any questions.
I know that certainly it was a lot of information, and a lot of information certainly has been coming in related to the treatment of COVID-19. So we thank you so much for sharing that with us and reviewing those important trials. And we will certainly continue to encourage persons to practice those public health recommendations as you advised, Dr. Bonamy. Thank you again. Our third presenter for this evening will be presenting to us on the topic, the profile of treatment and outcome of patients during COVID-19 in the Bahamas. We're so happy that our own Dr. Omala Black, who's been practicing with the PMH for some 20 years now. She is the consultant in internal medicine, as well as the director of the CME of Princess Margaret Hospital, and she will be our third presenter for this virtual session. Let's welcome Dr. Omala Black.
Okay, so thank you to UE and SCMR for the invitation, and Happy New Year to everyone. So my topic tonight is the profile of treatment and outcome of patients during COVID-19 in the Bahamas. What are the objectives? To review the epidemiology of COVID-19 in the Bahamas, discuss the protocols implemented at PMH to cope with the pandemic, review the evolution of treatment of COVID-19 patients, and Dr. Barnaby has done a great job of describing the evolution of treatment and what we've ended up in terms of efficacy, so I won't be going through that again. Neither could I do it like Dr. Barnaby. Thank you very much, Dr. Barnaby. Discuss the outcomes of patients treated with COVID-19 and review potential future treatment algorithms for PMH. And so basically with the epidemiology, we've heard this over and over. Our very first case was diagnosed at or around Sunday, the 15th of March, 2020. And that patient was exposed to a traveler but had not traveled. By March 20th, we were in a state of emergency and under curfew. By March 27th, Grand Bahama faced suspicious cases and the numbers continued to rise. There was a strong link to travel, and the Family Islands started to see what we felt were suspected cases. So if we look at our dashboard from the 27th of March, at that time, there were 10 confirmed, suspected, or recorded cases of COVID-19 in the Bahamas. From what we know now, our first wave was from around April to mid-June, and then we saw our second wave from early August to mid-November. As per our dashboard in late December, as we can see, there were a total of 7,623 confirmed cases of COVID-19 and 19 deaths. 163 deaths from COVID-19, sorry, which is 2.1% of all our positive cases. So to discuss the protocols implemented at PMH to cope with the pandemic. As early as February, we started preparing, and there was a CME on awareness, epidemiology, risks on February 12th, and Dr. Nakia Forbes did that presentation for us. Soon after that, our IPC department at PMH started training on donning and doffing. And in March, the University of the West Indies also had a symposium on COVID, and that was actually our very first CME where we left our classroom and face-to-face meetings, and that meeting was done live streaming with social distancing. The Minister of Health, Dr. Charlie Barnaby, Dr. Nakia Forbes, Dr. Jessica Edwards, and others did that meeting for us. Protocols were soon developed by the emergency room as our main or first port of entry of these patients for all suspect cases, and areas were identified for isolation and testing. As some or most of you would know, we started using what we call our old GPC area at the Princess Margaret Hospital to keep our persons under investigation or positive cases. And by the end of March, early April, our legacy unit, which is our mobile unit in the parking lot at PMH, was ready for use. Soon after our first case, there was closure of the hospital entrances. We started using just the front entrance. In-person clinics, elective surgeries, and visitation was halted. There were temperature checks and sanitization at the front entrance before patients, physicians, anyone was allowed to enter the hospital. And telemed clinics were started somewhere between the end of May, early June at the Princess Margaret Hospital. Different departments, different groups started in-hospital campaigns to educate on flattening the curve and why we needed to move forward with trying to encourage everyone to think about flattening the curve. There were media appearances by the chief of staff in the emergency room, our medical chief of staff, infectious diseases, and internal medicine head of department. Our employee health services were readied for evaluating, testing, and guiding exposed and ill staff. And the PMH staff also participated in assisting and manning the COVID hotline. Our ICU department developed a protocol for airway management. And as most of us would remember, at that point, we thought that, ventilation was a necessary part of the treatment. And there was a lot of hype and news about ventilator shortages and the risk of ventilation and spread. And Dr. Shea made plastic hoods to help the ICU staff intubate a little bit more safely. In hospital, we assembled our medical response teams, which consisted of internal medicine staff and emergency room staff in the beginning. As the pandemic progressed, midway during our first wave, we started seeing staff shortages because of exposures, quarantines, and people being off. Other departments chipped in. So we had people working in the medical response team who were members of obstetrics and gynecology, surgery, radiology, pathology, family medicine. Pediatrics manage all their pediatric patients. And of course, we had nursing and auxiliary staff that had to be assembled for the emergency response team. So early in the pandemic, patients were admitted to GPC or our COVID unit through the emergency room. These patients presented mostly with fever and shortness of breath and some cough. In the second wave, by mid-August, there were a lot more gastrointestinal symptoms, anosmia, negusia, and we started seeing new neurologic manifestations, especially in young females. And Dr. Barrett alluded to these neurologic manifestations. Also in July, we had a neurologist present to us through the CME department on the neurologic manifestations of COVID-19. Most of the patients were middle-aged to elderly, and most of them had comorbidities, hypertension, diabetes, heart failure, end-stage renal disease, malignancy, chemotherapy. There were a few SLE, sickle cell disease, asthma, and HIV patients. More so, we saw the SLE, asthma, HIV as the second wave started. So for those of you that may not have seen, this is what the legacy unit looks like. On the far right is what it looks like from the outside in our old parking lot across from the legacy entrance. And on the left-hand side, you see a shot of the inside, and that is at the back of the rooms. There are 4 rooms. Each room can hold 2 patients. And that is where staff would come out after coming out of the doffing room. And if you notice, there is a red piece of tape on the floor, and that tape helps us to identify dirty from clean so as to avoid cross-contamination. And so the summary of patient numbers, and these are just averages, not exact numbers. Presently, there are 5 active patients in the legacy unit. The capacity is 8. We are able to accommodate 4 patients for high flow and 1 for hemodialysis. Obstetrics and gynecology had their own protocols that they worked on, and there was a lot of ICU guidance with their patients as well. They saw 50 patients, 2 deaths. One was a 21-year-old and a 31-year-old. Private medical ward received most of the discharges from GPC. Some of them were COVID positive, and some of them were persons under investigation where it was the COVID-19 was ruled out. In total, from early May to November, GPC or all GPC COVID units saw 56 positive cases. And when they closed by mid-November, most of these cases were transferred to Samaritan's Purse unit or special pathogens unit, which was located in the front car park next to the blood bank. And in total, that unit saw 70 patients. Mild to moderate patients requiring supportive care were managed at South Beach Clinic. In the first wave, they saw around 30 admissions. There were no deaths, and they screened about 200 patients. In the second wave, they saw about 100 patients, 10 deaths, and they screened around 2,000 patients. Doctors Hospital from March to July saw 35 moderate to severe critical cases. Some were intubated, 6 deaths, which is 17%. And August to present, Doctors Hospital West has seen 135 patients, 29 deaths, which is 21% of the critically ill patients. And bear in mind that the patients at Doctors Hospital West is an overlap with the PMH critical patients that were transferred, as well as our end-stage renal disease patients, most of which are transferred there now for hemodialysis. In looking at the cause of death, most of the deaths were primarily as a result of respiratory failure, pneumonia, because of pneumonia, and the majority of deaths being related to pneumonia, PE, septic shock, and myocardial infarction. And so this is our special pathogens unit, and this is what it looked like. The picture on the left shows you the tent for donning, and the second picture is the doffing area. And the third picture shows you inside the tent, and that is Dr. Necker, who was one of our obstetrician gynecologist colleagues who joined us early on in the special pathogens unit and helped man it for almost 4 weeks while we transferred patients there out of our GPC and from other areas in hospital. So the PMH COVID census, I'm going to have Dr. Jason Thompson present that to you. Dr. Thompson has served as the registrar in the medical response team for most of the time that the team has been in existence. He is presently in the legacy unit as a consultant after having completed his DM Part 2 in December through all of this COVID. So congratulations to our new consultant, Dr. Thompson, and Dr. Thompson should be on the meeting. So it's all yours, Dr. Thompson.
Thank you, Dr. Block. Good evening, everybody. So the statistics that you guys are looking at now, basically from the second wave. During the time period, we had about 335 admissions. These include patients who came into hospital and also the admissions that we got from hospitalized patients when there were infections that broke out on the ward. Of the 335 patients, 88% of those patients, or 295, were internal medicine admissions. And the remainder were scattered between pediatric surgery and obs and gynae. We had roughly equal numbers for males and females. We had a mortality rate of hospitalized patients for about 18%. Of the 59 patients that died, 8 of those were deemed to be unrelated to COVID. In terms of comorbidities, we had about 30% of our patients that were diabetic, about 40% that were hypertensive, and about 7% of our patients were dialysis patients. Next slide. All right. And so if you look at the numbers broken down by age, these are percentages. So we had about 2% of our patients were less than 20 years of age. 19% were between 20 and 40. Between ages of 41 and 60, we had 38%. And between 61 and 80, we had 34%. And patients who were greater than 80, we had about 9% of those. So thank you, Dr. Block.
Thank you, Dr. Thompson. So the evolution of treatment and outpatient care. So there was a COVID-19 care pathway established at the local level for persons with suspected or confirmed COVID-19. A person enters the COVID-19 care pathway after he or she is screened. And this was done, like I said before, at the emergency room or South Beach Clinic. And it was based on standardized case definition and a questionnaire that was developed in the emergency room. The PUI, which is the person under investigation, was a suspect case referred to as a person under investigation. And a probable case are suspect cases for whom testing for SARS-CoV-2 is inconclusive or not available. And that was more in the beginning, as we now have testing more readily available. Confirmed cases are persons with laboratory confirmation of COVID-19. Those not requiring admission with mild disease were discharged with supportive care. And on the right-hand side, you see the pamphlet that they were discharged with, which was from the surveillance unit, and the surveillance team kept track of these patients. So treatment progression. I'm not going to really go through this slide as Dr. Barnaby elucidated the evidence and the evolution of treatment and how we ended up with effective therapy. However, in the beginning, we were a little bit wary of NSAIDs. However, at present, there's no evidence to indicate that there are severe adverse events in patients with COVID-19 as a result of the use of non-steroidal anti-inflammatory drugs. And, this came out in the WHO guideline that we're presently using which was printed on May 27th. In the beginning, we were not using dexamethasone, and you saw all the evidence for dexamethasone in the previous presentation. So we've been actively using dexamethasone since June in the patients who were on oxygen. There was care with the ACE inhibitors at the beginning. Now we're not really too concerned about the ACE inhibitors. Intubation was believed to be the best mode of treatment for the respiratory distress. Now we use more high flow, and in our legacy unit, we're able to accommodate 4 patients on high flow, like I said before. Prophylactic anticoagulation, especially in the patients with elevated D-dimers. And these patients were at high risk for PE, thromboembolism, renal impairment, and myocardial infarction. So these were some of the complications that we recognized in the days following admission for the critically ill patients. In the beginning, the controversial Plaquenil, we only use as salvage therapy, and we have not used that in any patients since probably June. The recognition of sepsis and fluid management in these admitted patients is something that we need to be mindful of. And the remdesivir, which is available since November at PMH through the Ministry of Health, has been used in 7 patients under ID guidance, and these patients were enrolled in the remdesivir trial. And so if anyone is interested, this is the guideline for management that we're using, and from 1 to 24 goes through all the information that you can access through this guideline, which is online. Inpatient care for moderate to severe patients, we follow WHO guidelines under ID supervision. We were using GPC and the legacy unit. The GPC unit has now been closed, and so is the SPU unit because we do not have any patients. The medical response team is still available, and there are a combination of team members in the medical response team, emergency medicine, internal medicine, ID, and all departments are available if needed. Oxygen therapy for respiratory distress or oxygen sats less than 90 to 92% is what we're using, and regular vital sign monitoring and additional testing as needed on a daily basis. We also update patients and their families daily, and in patients who are on high flow oxygen who may require intubation, ICU makes frequent rounds on these patients. The dual infection is also something we need to be mindful of, as these patients are also high risk for viral, bacterial, and fungal infection. So based on WHO guidelines, we follow the recommendation to still test for other viruses such as influenza A and B if needed, and to avoid antibiotic use in patients who may have mild COVID-19. Management of critical COVID-19 ARDS. Intubation should not be delayed if the patient acutely deteriorates or does not improve. And this is based on WHO guideline again. And like I said before, we follow this protocol in our legacy unit. So what are some of our conclusions? We do have some challenges with our legacy unit as it is located in our car park, not easily connected to the hospital. So access to imaging, transport of ill patients, supply delays have been an issue. And of course, we have a very small nursing pool, so we have burnout challenges, especially with hemodialysis, as there's only one hemodialysis nurse. And at some points, we may have as many as 9 hemodialysis COVID positive patients in hospital. We have seen a recent decrease in COVID admissions and also need for high flow respiratory support. On the right-hand side, you see the algorithm that we use at PMH for our COVID-19 patients. And what has been added to that in the second wave is PCR testing for all admissions since late December 2020. End-stage renal disease patients are transferred to Doctors Hospital West once there's an available spot. Isolation for mild to moderate, 10 days. Severe patients, 14 days. Our legacy unit presently has 5 patients, like I said earlier. All patients receive prophylaxis for VTE. We give hydration as needed, being mindful of fluid overload. Community-acquired pneumonia treatment as needed based on presentation. Dexamethasone for moderate to severe cases requiring oxygen, and high flow as needed. Remdesivir as per ID consultation guidance. So thank you. And I'd like to say a very special thank you to our medical response team, to our infectious disease consultants, Dr. Forbes and Dr. Barnaby, who are no strangers to us, Dr. Jessica Edwards, our microbiologist, who really works hard to get us those results on time, our nephrology team and consultant, Dr. Frederick Smith, the A&E COVID response team, and the South Beach team, and especially to Dr. Rivers, who manually went through the books to get me the numbers for you today. Our ICU team, Dr. Rowan, Dr. Turnquest, and Dr. Weish has worked on that team as well. So thank you very much. Dr. Isaacs has worked for surgical response for quite a long time on the COVID response team. And Dr. Griffith Bowe, who came up with the protocols and has helped with the obstetric gynecology patient management. And Dr. Jason Thompson, who's our senior registrar, who has now become our consultant at the Legacy Unit. So thank you to everyone and to our hardworking nurses, paramedical staff, support, and ancillary staff. If there are any questions, we can gladly take them at this time.
Thank you, Dr. Black, as well as Dr. Thompson, for the contribution to this presentation this evening. Are there any questions?
Hi, good evening. Can I ask a question?
Yes, go ahead, Dr. Chin.
Thank you so much, Dr. Black and Dr. Thompson. I just want to ask a question about BMI. Did anybody take a look at patients' BMI, especially the ones who passed away?
I don't think we really have that information, but I can tell you that the two obstetric patients who were very young, 20 and 31, I believe, would fit in the category of morbidly obese.
Oh, okay.
I don't know if Dr. Thompson has a comment on some of the other deaths.
No, it wasn't something that we did, that we looked at, but I think we noticed the same trend in the obstetrics patients that Dr. Black noticed with our patients in Legacy. We had a significant proportion of them that were morbidly obese and had respiratory problems outside of COVID. So some with obesity, hyperventilation syndrome, some with obstructive sleep apnea, prior to them being diagnosed with COVID.
Okay, thank you so much. Is there any way though that we could retroactively look at them and see if we could find those numbers or have an idea of obesity rate?
You know, unfortunately, because our census doesn't really chart weight, it definitely doesn't chart height. Yes, we could, but we would have to pull the notes and look at the nursing notes for height and weight. So it could be done.
All right, thank you so much. Appreciate it.
Thank you, Dr. Chin. Are there any other questions before we move on to our fourth and final speaker for the evening? Okay, I'm not seeing any in the chat. So thank you again, Dr. Black and Dr. Thompson. We're now going to move on to our final presentation for this evening. Our speaker will be speaking to us on the promise of a COVID vaccine, fact or fable. We're happy to welcome our own Dr. Nakia Forbes, the director of the National HIV/AIDS and Infectious Disease Program, the Ministry of Health. Let's welcome her.
Good evening, everyone. So it's my absolute pleasure to talk about COVID-19 vaccines, which seems to be a hot topic. So Dr. Robertson Halliday gave me a title, which was The Promise of a Vaccine. Is it fact or fable? So I have no financial disclosures, but in terms of my declaration of interest, I am a member of the COVID-19 Emergency Operations Center at the Ministry of Health, and I am a COVAX Strategic Plan Service Delivery member. So today I will be talking about the introduction and background of COVID-19. We'll talk a bit about vaccine development and why it's terribly important as a fundamental way of combating infectious diseases and indeed pandemics. We'll talk about the immunological basis for SARS-CoV-2 vaccination, and I'll talk about 3 of the vaccines that we're hearing a lot about And that's the Pfizer-BioNTech vaccine, the AstraZeneca vaccine, and the Moderna vaccine, although there are others, which I will share with you briefly. We'll talk about the nuances of vaccine availability and delivery and vaccine hesitancy. What does it mean? How can we combat it? Is it going to cause a barrier to vaccine uptake? And then I'll summarize and leave room for questions. So as we've already heard, in 2019, there was a novel coronavirus that was identified, and this became known as the Severe Acute Respiratory Syndrome coronavirus, or SARS-CoV-2. It was identified as a cause of a cluster of pneumonia cases in Wuhan, China, and in February 2020, this disease was termed COVID-19. There was rapid spread, which led to a global pandemic. And indeed, we heard that this is a health emergency of international concern. So in terms of the worldwide statistics as of this afternoon, there are about 97 million lab-confirmed cases of COVID-19 or SARS-CoV-2 worldwide. Over 2 million persons have died of COVID-19. It's about 2,082,000. In the Caribbean, we have not gone unscathed. There's a heat map looking at the COVID-19 outbreak that's affected most of our countries. And we know that there have been various waves and surges. And there have been roughly 425,000 cases in the Caribbean with about 6,312 deaths. And here in the Bahamas, we had 2 waves of COVID-19 with about 8,075 cases as of yesterday's report and 175 related COVID deaths. And so we know that mortality from COVID-19 can vary from place to place, but when you take your chances with coronavirus, there are a substantial number of persons, 5%, that will have critical illness and can end up in ICU and indeed lose their lives. And so it is a huge global concern. And that can be across ages. Now, when we think about the impact of vaccines in the Americas, it's very important that we note that overall vaccines are very impactful for preventing communicable diseases. And what is the burden of some of these communicable diseases? So I put some pictures in my presentation. Here you see this young lady. She had flaccid paralysis from polio. And that is certainly very, very debilitating. And so does this young man here that needs some braces, and he is going to be quite disabled because of the flaccid paralysis associated with polio, which was indeed a problem in previous times, but it has been eliminated widely from the world. And this little fellow here has smallpox. So with smallpox, people who were not vaccinated, there was a 50% mortality. Can you imagine that? So we talk about things like the mortality associated with COVID-19. It can be up to 2% in the general population. We're hearing that there's high mortality in hospitalized patients. But imagine a virus that causes 50% mortality. And smallpox has been eradicated. It's nowhere. It's except for in our research lab, there are no more natural cases in the world. And this has been a huge success story based upon the impact of vaccines in the Americas. So here, this is a little clip from a WHO poster that talks about what happened before vaccines. There were many cases of polio in the 4 years, 234,000, millions of cases of measles, and vaccines have certainly made a significant impact and dented these infections down to either eradication or very low levels. So vaccines to prevent SARS-CoV-2 are considered the most promising approach for curbing the pandemic. They're going to be a very important part. Vaccines are being rigorously pursued, and there are actually many vaccines that are somewhere in the pipeline. They're either in clinical trials or in preclinical trials. And there are several vaccines already available for use in different parts of the world. So this is the landscape of the novel coronavirus candidate vaccine development schedule. And this is available from the World Health Organization. I took a clip of this on Friday past. And so at that time, there were 64 COVID or SARS-CoV-2 vaccines in clinical development. And there were a number in preclinical development, up to 173. There are different vaccine technologies. We've been hearing about this new technology, the mRNA vaccine. We're going to talk more about that and what that means, but there are certainly other kinds of viral platforms related to the COVID-19 vaccines, and I'll talk about those in brief. Now, down here, this little circle pictogram, it tells you a bit about the doses for these vaccines. So we've heard that some of the vaccines, for example, Pfizer, the Oxford vaccine, and Moderna, they're going to require 2 doses. But there are certainly vaccines that are in development now that may have only 1 dose, and that's about 17% here in the blue. And there are some that may require 3 doses and others that are not specified. Last week in our symposium, Dr. Sinqui asked about other routes of administration. And you can see, and you can go and look at the site for yourself, that there are going to be a variety of routes of administration. There can be nasal administration, there could be subcutaneous, intramuscular, intradermal, and oral, and those are all being researched. Let's talk about vaccine development. And so one of the things about the SARS-CoV-2 vaccine is that it was accelerated, it was fast-tracked, and that in itself is something that we need to talk a little bit about so that we understand what it means, because safety is still very paramount in terms of the development of these vaccines. And there can be the misinformation that because the vaccines were accelerated, that safety was cut cornered, and that is not exactly what happened. And so let's just take a review of how you develop a vaccine. So traditionally, there is an exploratory phase. There's a preclinical phase, clinical trials, the FDA review and approval process, which can only happen after these clinical trials are completed, and then an acceleration of manufacturing. And so for a candidate vaccine, certain fundamental questions have to be asked. Is the vaccine effective? What is that effectiveness going to mean? Is it going to mean that you cannot get SARS-CoV-2 infection? Does it mean you will not be able to get the disease? Does it mean that if you get the disease, you will not become critically ill? And so those are some of the things that we look at when we talk about vaccine efficacy, or will you be able to transmit it to others? Is the vaccine safe? Are there adverse effects associated with the vaccine? And if there are adverse effects, what are they? Are they mild, moderate, severe, critical? What % of people have these? And of course, in the beginning phase, they want to know things about the immunology. How's it going to work? How could it be postulated to work? Is there any previous work that has been done on these vaccines? And the answer to that is yes. There was a lot of work that was done in the previous 10 or more years looking at these kinds of vaccines, which allowed a platform to be used in the exploratory phase. Then you go on to preclinical testing, and that is when the vaccine is tested in animals, and this has to be done before human trials. Safety, dosage, and immunity is something that is challenged in this part of the vaccine. And then, as we know from our basic science training, there are phases of clinical trials with phase 1, phase 2, and phase 3 trials. Phase 1 just has a small number of persons. It could be hundreds. They look at the clinical test, the doses, safety, and the optimal dose. Phase 2, there are hundreds to thousands of persons. You look at the rate and the delivery of the doses, the immunization schedule, and again, safety. And phase 3, this is where most clinical trials enroll people across countries and across cities, multiple persons of different backgrounds with different comorbidities to further get information on safety, efficacy, immunity, and again, robust safety. Only after those processes are completed can a vaccine candidate be entered for FDA review and approval, and we'll talk more about what that means. Now, there is such a thing called an accelerated timeline for the development of vaccines, and that can be done when you do have public health emergencies of international concern, for example. So these phases are not cut short. There is some overlap, but there has to be robust safety information, and the exploratory preclinical and clinical phases still continue before FDA review and approval. And that was done in COVID-19. So again, this is on accelerated timeline. And so this is essentially what we saw in COVID-19. How was this enabled to happen? So I put here on this slide that lessons were learned from other coronaviruses. So we know SARS-CoV-2 and the first SARS and the MERS coronavirus are all in the same family of coronaviruses. So you will see that the first SARS was described in 2003, and then it went away. And MERS was described in 2012. And so there was work from vaccine development for these two viruses. There was preclinical studies looking at those viruses, and there were small human trials. And work halted when these viruses were eliminated from circulation. Now, in the time of COVID-19, one really good thing that came out of it was collaboration from scientists worldwide and information sharing, which is a really good thing. So in January, very, very early in January 18th, actually, the genetic structure of SARS-CoV-2 was shared and known. And it was known that there was a spike protein. So we've been hearing a lot about the spike protein. We saw that in other presentations where it can bind to cells using the ACE receptors. So this is an antigenic target. So there are other spike proteins that are analogous proteins in these other two vaccines. And so it was not difficult to swap these in to create a vaccine, in that all of this work had been done on previous platforms. And as a matter of fact, the first candidate vaccine was being brainstormed and created a few days after the genetic sequence and the structure of SARS-CoV-2 was published and shared globally, so that scientists could accelerate the development of a potential solution in terms of a vaccine. There were concerns in the previous vaccines developed for these two other viruses about something called vaccine-enhanced disease. Will getting the vaccine when you are exposed to natural infection cause an enhanced disease course? And that was not demonstrated. So there was work done. So immunization for SARS-CoV-2 is actually a fact. There's facts that show that there's an immunological basis for these vaccinations. There are observational studies that support the concept that vaccination has the potential to prevent SARS-CoV-2 infection. And this was in the preclinical studies in non-human primates. In these studies, these primates were protected from the wild type virus after they got the vaccine. And they were protected after a viral challenge, and they developed functional neutralizing antibodies, and that correlated with protection. That was also demonstrated in humans during the trials. And so we know the vaccines elicit a sufficient neutralizing response and offer protection against COVID-19. So as I said, there are many different vaccines. And so here in this slide, this is a cartoon about the different ways that a vaccine can be created for SARS-CoV-2. And so we have the mRNA vaccines, we have DNA vaccines. There are vaccines that look at the virus-like particles. Subunits can be used. There's inactivated virus, there's attenuated virus, and viral vectors. So first I'm going to talk about the RNA vaccines, because those Pfizer and Moderna use that technology. So these were the first vaccines for SARS-CoV to be produced. And it was an entirely new vaccine approach. We need to know the facts as it relates to that. The RNA is translated into target proteins, and this elicits an immune response. So that's basically the premise of how vaccines work. They elicit an immune response, but they don't cause disease. The mRNA remains in the cell cytoplasm. It doesn't enter the nucleus at all. It doesn't interact or integrate into the recipient's DNA. And the challenge with some of these is that it has to be maintained at very low temperatures, and that can complicate storage. So this ultra cold chain storage is between minus 180 to minus 80 to minus 60 degrees. And so that can be challenging as it relates to the supply chain and management of these cold chains. And like I said, the examples are Pfizer and Moderna. So DNA vaccines are still in clinical trials. They're inactivated vaccines produced by growing SARS-CoV-2 in cell culture and then inactivating the virus. We know about live attenuated vaccines, for example, the flu vaccine. It's a genetically weakened version of the wild type of the virus that will not cause disease. And there are others like recombinant protein vaccines and the vector vaccine. For example, the Oxford vaccine is a vector vaccine. So just to give you a snapshot of how common some of these are, you can see protein-based is probably the most prevalent in development, and then there are others that are in the pipeline. So I'm going to take some time to talk in more detail about 3 of the vaccines that we're hearing a lot about, and albeit there are more. So I will start by talking about the Pfizer-BioNTech vaccine. It's an mRNA vaccine. It has been granted emergency use authorization by the FDA. So essentially what that means is that after an independent review board and safety had been assured, the risks and the benefits were weighed, and the benefits of these vaccines are considered to outweigh the risks significantly, allowing them to have emergency use authorization, but safety information is also ongoing and continues to be collected even after the phases of clinical trials. So this vaccine is administered in 2 intramuscular doses, approximately 3 weeks apart. It's delivered in a lipid nanoparticle, and that expresses a full length of spike protein. It's already being used in the United States, the United Kingdom, the European Union, and Canada. And there was a very large placebo-controlled phase 3 trial, and you can research the data from the phase 2 and the phase 1 studies as well. And what it showed is that there was a 95% efficacy in preventing COVID-19 at or after day 7 following the second dose. So of those that were in the vaccine group, there were 8 COVID cases and 162 in the placebo group. And the trial was quite large. It had about 36,000 participants that were aged 16 years and older. And in terms of the severe cases, 9 of those 10 were actually in the placebo group and not the persons that had the vaccine. And so here, when you look at this graph, this blue line is pretty flat for those persons who got the vaccine that developed any disease versus those persons who got the placebo and whether they developed COVID-19. When we think about adverse events, there are local and systemic adverse events, and those were dose dependent. And they were relatively common after the second dose, and they were mainly mild to moderate. And so I've just placed here the frequency or the percentage of the reports of persons having these adverse effects reported in the trial. And so fever was reported in 4% of participants, fatigue in 3%, headache and chills in 2% respectively. Now, we've been hearing a bit about anaphylaxis, and that is very uncommon. And basically, it is basically at a rate of 1.1 per million doses, and it's more common for those that have a history of allergy or anaphylaxis or hives to foods and medicines previously. There are also rare cases of Bell's palsy, but that was not exceeding the rate in the general population, and it's being monitored. What about the Moderna vaccine? That's another mRNA vaccine. There are 2 intramuscular doses. It's given 28 days apart. It has similar technology. It utilizes mRNA. It delivers a lipid nanoparticle that allows expression of a full-length spike protein. It's authorized for use in the US and the EU. In phase 3 trials, the findings were quite similar. The efficacy was 94.1% in preventing symptomatic COVID-19 at or after 14 days following the second dose. And they looked at how many persons after an analysis got confirmed COVID-19. There were 196. There were 11 in the vaccine group compared to 185 in the placebo group. There were more than 30,000 people in that part of the study. And 30 cases of severe COVID-19 in all occurred in the placebo group. And you can see here that I've listed the adverse effects. 17% of participants reported fever, 10% had severe fatigue, 5% had headache, 10% had myalgias and arthralgias. And similarly, you can see here in the red line, these are the people who got the vaccine versus the placebo and the rate of COVID-19 that was acquired or the infections that happened in that study. So it was very effective. Lastly, I'm going to talk about the Oxford, AstraZeneca, and Serum Institute of India vaccine because it's a shared platform. So it's a vector vaccine. It's an adenovirus vector vaccine. So you usually choose a virus that's relatively not going to cause a problem, that expresses a spike protein. It's given IM. It was evaluated. So there was a little bit of a mix-up in this study. They evaluated 1 dose and 2 doses 28 days apart, and then they looked at the antibody titers. And that still needs to be worked out So the levels of antibody titers achieved a higher titer following 2 doses. It was also a good quality study. It was multinational. It was randomized. They reported an overall 70.4% efficacy in preventing symptomatic COVID at or after 14 days following the second dose. There were 30 cases in the vaccine group and 101 in the control and 11,000 participants. And again, the adverse effects were relatively mild to moderate and are as previously listed: fatigue, headache, and fever. There were 2 cases of transverse myelitis that are being looked at. One was possibly vaccine related and the other one was undiagnosed MS. Okay then, so that's the science as it relates to these vaccines. Let me just say that there are other vaccines that are in the pipeline and that are being utilized. There is a Chinese vaccine and there is a Russian vaccine that are in use in some countries. So overall, after you have an effective vaccine and you have answered the question, is it useful? Is it efficacious? Is it safe? Does it do what it's purported to do? And can it be developed and rolled out quickly? Once all of that has been established, and it has, and the various phases of clinical research are concluded, then you get to the licensing vaccine step. So I've given you an example of what that looks like. In the United States, the Food and Drug Administration does that. And this is after phase 3 trials are concluded and adverse effects, again, have to be presented and discussed by an independent review board. There is a decision to license and what limitations there are. And so an EUA, or emergency use authorization, can be granted if the benefits outweigh the risk and safety assessments are ongoing. And there are other approaches that are quite similar to this from other regulatory bodies that you can see in Europe and Canada, for example. Now, when we consider vaccine availability, we have to consider other things. So remember, my topic was fact or fable, the promise of a COVID vaccine. So having a vaccine is one thing, but vaccinations are what prevents infections and save lives. So as you've heard, you have to get it into the arms of people. You have to look at accessibility, funding. You have to look at the technical requirements for storage and handling. And again, this can prove challenging if you need an ultra cold chain. Not all of the vaccines need that. Some of them can be kept at warmer temperatures, which are usually within the range of what a commercial freezer can do. There also has to be systems to provide access to vaccines and reducing barriers as needed. And then there's this herd immunity principle, which basically, in a nutshell, speaks to the number of persons or the percentage of persons in a population that generally have to have immunity for infectious diseases not to be spreading widely. That's usually around 60 to 70%. Remember, herd immunity can happen in various ways. It can happen from natural infection, but we would rather that happen from vaccines because that's far safer. So there has to be fairness, transparency, and evidence-based, and there are ethical principles related to the allocation of vaccines and how they can be deployed in equitable ways. How do you prioritize these? If the world's population, except for those people who have had COVID-19 already, are susceptible to getting SARS-CoV-2, you have to look at those who are more likely to do poorly and have critical illness or die. So you have to think of those that have a high risk for acquiring infection, have severe morbidity and mortality. We heard diabetics, hypertensives, people with end-stage renal disease and obesity. You have to think about groups of persons whom, if are impacted, there would be a negative societal impact. So think about if a large number of frontline workers were impacted. We saw earlier in the epidemic that we looked at the percentage of healthcare workers and frontline workers that were impacted, and we saw how that ranged compared to the rest of the world. And so we have to think about what happens when large numbers of persons are in quarantine or not able to be at work, carrying out their work. And in that case, it could be offering care. There are other groups of society that this is also relevant to. You have to think about transmission of others to others. And so you have to think about this in terms of vaccine capacity and expansion. I'm going to talk briefly about COVAX. So COVAX is a World Health Organization platform, and this is a way that developing countries can have accessibility to COVID-19 or SARS-CoV-2 vaccines. There has been a promised number of doses, and we have to think about how that looks as developed countries and resource countries compete for doses of available vaccine. We've heard that through COVAX, the Caribbean may expect to get SARS-CoV-2 vaccines as early as the first quarter of 2021, maybe as early as spring. And certainly there are countries that are United Kingdom, overseas territories that have received their first doses of vaccine in the Caribbean. So you have to get the vaccine into the arms of people. It's not just having vaccine, it's about having a plan, and does it translate to vaccinations? And so we have seen that vaccines can be available, but if they are not being given through a robust vaccination program with uptake, that there will be a suboptimal vaccination rate. And so vaccine hesitancy is a large obstacle to achieving vaccination coverage that's broad enough to result in herd immunity and slow community transmission. And this is a worldwide problem. It didn't just happen with SARS-CoV-2 vaccines. It is something that we see in terms of other vaccines. For example, the measles, mumps, and rubella vaccine. There was the anti-vaxxers movement. There's the fallacy that vaccines could be associated with autism that is going around as a conspiracy theory. And so the WHO actually mentioned that the top 10 global health threats include vaccine hesitancy, and it's a common problem worldwide. Now, as we look at the vaccine hesitancy about the SARS-CoV-2 vaccine, there's a number of reasons why there is vaccine hesitancy that is rearing up with this particular vaccine. The first thing is there was an accelerated nature of development of these vaccines because it was very important. As you saw, what happened in 2020, this was a huge crisis, but this led to the perception that corners were cut with safety assessments, and I hope I've debunked that. There's misinformation about the severity of COVID-19. There are some people that still believe it's a flu, but remember, SARS-CoV-2 is 10 times as lethal. The mortality is higher than the flu. There's skepticism about the utility. I hope I've debunked that through my slides. We have to look at reasons for vaccine hesitancy and look at characteristics associated with vaccine refusal. And we have to tailor those approaches because people have to have confidence in the vaccine to take it. There's also mistrust, especially among certain marginalized communities. We've heard about the Guatemala STI study and the Tuskegee study. And so there is mistrust for a good reason for science in some regards. And so we cannot discard it if we're going to combat vaccine hesitancy. We have to get to the bottom of it and educate and try to debunk myths if we're going to get through this. So this slide looks at the vaccine hesitancy that was reported from country to country, and it varies. So the answer to one simple question, if a COVID-19 vaccine is available, I will take it, true or false, was done in this particular study. And we can see here that it varied. So these bars look at the highest to lowest here on the right, percentage of persons who answered in the affirmative that I will take this vaccine. In China, 88.62% said yes, they would. And then it went down all the way down to 54%, below 55% in Russia. And you can see there are various countries here reported. There's also information from the Caribbean that looks at some of the countries and what did people say in terms of vaccine hesitancy? And we do have a ways to go as it relates to combating vaccine hesitancy before these vaccines arrive. So this is another study that looked at attitudes toward a potential SARS-CoV-2 vaccine. It was a survey of US adults. This was done early. It was a phone survey. It was done early in the outbreak in April, and persons were asked to measure their intent of being vaccinated against COVID-19 by answering the question, when a vaccine for COVID becomes available, will you get vaccinated? And the answers were yes, no, I'm not sure. If you said no and not sure, they were asked to give a reason. So just under 1,000 persons responded. 57% said they would want to be vaccinated. 31% said they were not sure. 10% said no, they had no intention of being vaccinated. And there were factors that were associated, like a younger age, lower educational attainment, not having received the flu vaccine. And the reasons given were vaccine-specific concerns, I need more information, anti-vaccine attitudes or beliefs, and a lack of trust. What can we do as healthcare providers to combat vaccine hesitancy? We can improve vaccine acceptance in individual patients by making direct recommendations for vaccination, identifying the concerns, educating patients on the vaccine risks and benefits, and dispelling misconceptions about the disease and the vaccine. So there are still questions that need to be answered about COVID-19 vaccines. For completion, I thought that I would put that in. We don't know yet, and hopefully trials will continue that will answer the questions. Is there protection against asymptomatic infection? Will having the COVID-19 vaccine reduce the chance of transmitting SARS-CoV-2 if you have the vaccine, if you do get the infection? What's the duration of protection from disease? Is there going to be the need for and the timing of additional booster doses? What are the efficacy in subpopulations not evaluated in clinical trials? For example, children, those under the age of 16, pregnant women, although it's not contraindicated according to the ACOG. And you have to look at the risk versus the benefit, but I think we'll get that information as we go on. What will be the impact on herd immunity? And we need to work out the dosing in the Oxford vaccine. And so in summary, COVID-19 is a global pandemic with a large burden of the disease and deaths, upward of 2 million to date. SARS-CoV-2 may be vaccinated against with high efficacy, and that's a fact. And SARS-CoV-2 vaccines are an important aspect in the fight to end the pandemic. Several vaccines are being rolled out in various countries, and there are many in the pipeline. They have different mechanisms of action, and there are some newer technologies, but they're using previously used platforms. It's important to identify the risk versus the benefit, and the benefit of this vaccine certainly outweighs the risk of adverse effects, which were largely mild to moderate and not in the majority of persons who are enrolled in clinical studies. We have to look too at matters related to distribution, availability, accessibility that has to be addressed. And so fictions and myths about the vaccine have to be cleared up, and vaccine hesitancy is a part of that. And we have to remember that vaccinations are what stops infections and disease. I thought I would just mention here that this vaccine will not be mandatory, because that is a question that I get asked a lot. And so I do hope I answered the charge that the organizers asked me, is a promise of a COVID vaccine fact or fable? And so we know there's a fact that it is vaccinatable, and there are certainly vaccines that are available in the pipeline. But for this to be a reality, we have to look at how vaccinations become a reality and planning and the support mechanisms for vaccinations. Thank you very much, and I'll pause if you have any questions.
Thank you, Dr. Forbes. Do we have any questions for Dr. Forbes at this time?
I have a question, Dr. Pinder Butler, Dr. Hannah here, with regard to safety profiles, particularly in women of childbearing age, pregnant females. Is there any thought or input that Dr. Nakia Forbes can give to that?
Hi, Dr. Hannah. Good to hear your voice again. So the thing is, pregnant women were not part of whom was supposed to be enrolled in these trials. But as life has it, you're not pregnant when you get in the study, and you find out later on that you are pregnant. And so there were some pregnant women that ended up in some of these studies, and there were no problems, there were no developmental problems or adverse effects reported, but that information is going to be looked at in more detail as subpopulations of studies of persons in studies. For example, children. Remember, some of these studies, the age group was 16 or 18 years and older. So we have to see what it's going to look like in children and pregnant women. So we don't think there's an issue right now, but you know, we don't go by what we think, we go by what science says. So I think we'll have that as we go forward.
Thank you.
You're welcome.
You can unmute your mic and ask the questions.
Dr. Forbes, Dr. Sinqui here. Thank you very much. And, you know, I'd like to congratulate the entire platform of speakers. Very well done. Just wanted to find out if you can just say which vaccine was chosen for the Bahamas. If you can just remind us on that, and whether or not you foresee a reliable supply for the vaccine once it rolls out.
That's a very good question. So the vaccines for the Bahamas, one of the platforms is going to be COVAX through the World Health Organization. And so there is usually more than one candidate when we look at the modalities and the other treatment modalities that are available through the World Health Organization. It would be prudent for us to look at a variety of vaccines. So the Pfizer and the Moderna vaccine are very efficacious, but Pfizer has to be kept at -70 degrees. Moderna can be kept at warmer temperatures like -20 degrees, but it would be good to have options. And we would have to see what happens as other vaccines we're hearing, like Johnson & Johnson, may have a 1 dose, which could be helpful if you're looking at vaccinating a large subsection of the population to try and get herd immunity. So it's not quite clear yet which one of these we will get. Now, challenges related to rollout. So it's not just the Bahamas, it's worldwide. So having available vaccines doesn't mean that you have vaccinations. So there are some little nuances about these things that I didn't mention. But for example, the Pfizer vaccine, it has about 5 or 6 doses. If you use a zero gravity needle, you say you can squeeze an extra dose out of the vial. But once it is open, you have to use it all within a certain period of time. And so you have to be very organized for that. You don't want the vaccine to waste. You have to think about vaccine sites. You have to think about rollout, training, the platform to monitor and evaluate these vaccines, the supply chain. And there's another thing that is it's a reality. And that is vaccine accessibility. So remember, this thing it's a hot commodity right now. All the countries in the world want to have this. And so when we look at cost, if there's a developed country and they can buy 2 billion doses, how much does that leave for everyone else? And so we have to look at the ratio of these vaccines, how much will be allocated for the developing world, and how are we going to roll it out? Those are some of the issues. And I hope I covered some of the other issues as it relates to accessibility and equitability, and how you will tackle that. Because at the end of the day, what you really need is herd immunity. If a country will end COVID-19, vaccine-wise only.
Yes, Dr. Forbes, Dr. Barrett here. Thank you for that very comprehensive presentation. The Johnson & Johnson vaccine, which requires 1 dose, what's your feeling on that in relation to the type of vaccine it is, the science behind it, and would it be less costly because they said they can produce 1 billion doses over the course of a year? That's what they're claiming. Would it be more prudent for us to get the 1 dose in terms of cost effectiveness as well as efficacy?
Good question. We don't know yet because it's still in the clinical trial. It hasn't received EUA yet. We're hoping that will happen soon. But until that happens, there's still information that we need to gather. and we would have to look at the platforms for how to get that vaccine, just like all the others.
Thank you.
You're welcome.
Dr. Forbes, can you also comment on the administration of the vaccine, whether or not it would be more prudent to give a single dose to as many people as possible, or to try and complete the series for the higher risk patients? Can you make a comment on that for me, please?
Yeah, definitely. So that's a hot question. And so, like I said, the vaccines are a hot commodity. There doesn't seem to be any left over, like a second tranche. And so countries are wondering, could you just give the first dose, because there is some immunity after 2 weeks after the first dose, and kind of look at it that way and ration it. But it's not recommended at all, because it wasn't looked at in clinical trials, and it's highly likely that you won't get the full efficacy at this time. So that's absolutely not recommended at this time.
Good night, Dr. Forbes.
Hi, Dr.
Thank you for a great presentation. The general population is looking quite attentively at what physicians are doing. There seems to be a high level of uncertainty as to whether physicians think that these vaccines are worth taking. What is your advice to us as physicians as to, we see the information, we see the evidence, but what is your advice to us as to whether we should take the vaccine or not?
Right. So the vaccine, it will not be mandatory to anybody, physicians included. I recommend that persons, including us, read the information about these vaccines and how likely you are to have an adverse event. Most people in clinical trials, just like medicines and therapeutic modalities, most people don't have adverse events for drugs that are approved. So safety is very stringent. By the time something could get emergency use authorization, safety had to be pretty much guaranteed and looked at and scrutinized. But like I said, there are reasons why there's vaccine hesitancy. So I encourage people to read the information and decide for yourself. I personally will get the vaccine when it's my turn. And I hope that I help to dispel some common myths about these vaccines. Again, like I said, there are many reasons why this was able to be accelerated, and that's actually a success story. But sometimes when things like this happen in a way that we think is unprecedented, there could be some sort of distrust. And so there are other vaccines that have been developed quickly. Certainly there's a huge risk. I don't want to take my chance. I would rather not take my chance with COVID-19. I prefer to get a vaccine. Even if there are mild to moderate side effects that I'm not very likely to get. And like I said, this technology, part of the reason why this was able to be developed so quickly is because of SARS and MERS. And basically this quick sharing of the vaccine, of the COVID-19 structure, which allowed an easy swap for the spike protein in the mRNA development of these vaccines, so that there could be a vaccine candidate very, very quickly. And once that's done in all the preclinical evaluations, it doesn't take long to actually formulate it, but it has to go through clinical trials, which was accelerated.
And on your part, concern on the part of getting out, how can that be addressed?
You broke up a little bit there, Dr. Williams. I didn't hear that.
Concern that there is inadequate education of patients, and by the time it is there will avoid it and
I might be having internet problems. Did
think-
you hear that, Sabrika?
He broke up as well again. Francis, can you try one more time? I think you're
Or
asking.
you could type it.
Dr. Franklin, are you available?
Hold on. Dr. Forbes, Dr. Frankson here.
Hello,
Can you
Dr.
hear me?
Frankston.
May I be permitted to ask a question, Madam Chair?
Go ahead,
Okay.
Dr. Frankson.
Okay. The COVID ambassadors, what role are they emerging into as we deal with this very issue of hesitancy?
I don't know. Sorry, I don't. They're not my platform.
I'm sad to hear that, because I have a great faith in the potential for them, because they speak the layman's language, and when prepared, I don't see why they wouldn't be a very effective force.
I agree with you.
Dr. Forbes, thank you for that great presentation. I just wanted to know, since we are not sure of the long-term effects of this new technology of mRNA vaccine, how can we be reassured to take the vaccine?
Yes, so safety is ongoing, but safety reports are ongoing. But essentially, I think that it's helpful to understand how these vaccines work. So in this regard, it's an mRNA vaccine. So what it does is it causes cells, it doesn't interact with the nucleus, but it causes cells to express the spike protein of SARS-CoV-2, upon which neutralizing antibody response is generated and a T cell response, so that in exposure to wild type SARS-CoV, the actual virus, you will already have an immune response that can kick in to neutralize this antigen. And so when you think about it, although the delivery vaccine platform is new in terms of availability and uptake of an available vaccine, but it has been studied before in SARS-CoV-1 with no long-term adverse effects, side effects, or even enhanced disease enhancement. I do think that that's promising. And so it's helpful when we think about what vaccines do. They essentially cause an immune response without disease. And so this would be no different.
Thank you, Dr. Forbes.
You're welcome.
Okay, so Dr. Williams is saying that his question was similar to Dr. Frankson's. He wanted to ask about the education process for the general public related to the vaccine rollout.
That's important. That has to happen. It's very important as it relates to vaccine uptake and people's understanding of the vaccine, and it will help vaccinations. It's an important part. I did see that this was mentioned this week as it relates to countries readying themselves and their response and educating for when vaccines are available.
Okay.
Hello.
Dr. Van Toren?
Yeah, great talk, Dr. Forbes. Just like to ask you a few questions on this, excuse the voice, on COVAX. Is COVAX roughly been used for years ago? They are attenuated or kill virus?
It depends on the vaccine.
So they're similar to like rubella, not rubella, smallpox and so on?
So I think I stopped sharing my slide, but there are certain vaccine platforms in general, vectors, live, attenuated, looking at protein particles. And so when you look at the almost 200 vaccine candidates that are in clinical and preclinical trials, there's a breakdown for how many of these will be those various platforms. Let me go back to it and I'll tell you what percent. 5%, just over between 5 and 10% are virus. Viral vector is about maybe half of that, 12.5%, based upon the recent WHO platform. Nucleic acid, about 20%, including DNA and RNA. Protein-based accounted for about maybe 32.5%, and there are other accounting for about 7.5%. But largely the Pfizer and the Moderna are nucleic acid vaccines. The Oxford is a viral vector, an adenovirus viral vector. And that is how those work. But there are other vaccines in the pipeline.
Yeah, I'm just more concerned about practicality in using, like in the Caribbean, or certain vaccines that for example, I personally have vaccinated about 1,000 people with smallpox vaccine in 72, 73. Now the smallpox vaccine the immunity lasts for quite a long time. How long, obviously one can't say how long this vaccine is out now, Pfizer, Moderna, so on, how long they will last immunity. We can't really say that at the moment, can we?
We don't know. That is unfortunately a knowledge gap that we have. We do not know how long immunity will last. Just like we don't know for sure how long immunity is going to last with natural infection, depending on who you are. Is it months, years? So we would hope to have that information as more information comes in.
Because I've just heard this yesterday about reinfection in Rotterdam, Netherlands, that a couple of patients, one of them is a nurse's assistant, had a reinfection after about 3 months. So they're saying maybe the immunity does tend to fade away for some person. And like we know about COVID-1, there's still some people that when they did the antibody test, 3 years later, they were still positive, and some didn't last that long. So I'm just wondering whether this reinfection means in some patients, the immunity will not last for long, whether you give a vaccine or not. And second, coming to that, was I just had a couple of friends who rang me and say, I just got, I was supposed to have the vaccine this week, but I just, curiosity, did a antibody test. It was positive. So I'm going to leave it for what the FDA have said, 90 days before I get the next shot. And then he suddenly also changed his mind and say, I'm not going to get the vaccine. Why should I get the vaccine? I already got the disease. What is your opinion about the vaccine if you already had COVID?
Very, very good topical point. So we know that people can get reinfected with SARS-CoV-2, but it's uncommon based upon what the scientific literature says right now. And there's a clear definition for how you should consider that. And it's highly unlikely in the first 3 months. And not only that, you need to have compatible signs and symptoms. And largely, you have to demonstrate that this really is a reinfection rather than long symptoms, because there can be symptoms. And there's an article that came out not too long ago looking at people who had a COVID-19 and reporting respiratory symptoms and still having positive tests and so on weeks later. And so there's a clear context for this. So there is actually a definition for how you define reinfection. You can't just willy-nilly say that someone has a reinfection. You have to demonstrate that there is a different phylogenetic strain.
I think this was demonstrated. Yeah.
But it can happen. So it's rare, but it can happen. And so it's a gap in our knowledge. I mean, there's many things we don't know about COVID-19. It is a new virus. How much do you need to get infected? Do you breathe in a couple particles and you get infected? You need a whole lot to get infected. Is that going to impact immunity? We just don't know. And then the other thing is vaccine immunity is different than natural infection immunity, because there would be cross reactivity and other things. But again, at the end of the day, it still remains to be seen if you're going to need a booster. And I guess we'll know that as time goes on about neutralizing antibody titers and so on. Now, your second question is also a very good point. If you have antibody already, if you've already had SARS-CoV-2 or COVID-19, do you need a vaccine? And the answer is yes, because remember, there are other strains and it doesn't guarantee that you won't get COVID-19 again. We've already established that you can be reinfected. And so again, a vaccination platform is very different than a natural infection platform. And so at this time, experts recommend that even if you have had COVID-19 SARS coronavirus 2, you should still get the vaccine. But if you acutely get COVID-19, say you've gotten one dose of the vaccine and you get COVID-19, it can happen. You have a little wiggle room because you have a bit of immunity, but you should still get the vaccine and complete the series, basically.
Yeah. Thank you very much, Stephen.
Thank you again, Dr. Forbes, for your presentation. And we want to also thank all of the presenters this evening for presenting, as well as we want to also thank the UWI School of Clinical Medicine Research, as well as the PHA and the Ministry of Health for putting on this virtual symposium. Thank you to all of you that have come out this evening, and thank you for allowing me to be a moderator for this evening's virtual symposium. Good evening.